Hello, everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Ventilatory Strategies for the Patient with the Flu. And now I'd like to introduce you to Brady Scott, who is our moderator today. Brady is the Director of Clinical Education and Assistant Professor for the Respiratory Care Program at the College of Health Sciences of Rush University, Chicago. He has been a respiratory therapist for more than 15 years with clinical practice experience in adult emergency and critical respiratory care. In 2007, he was named the Adult Acute Care Specialty Practitioner of the Year by the American Association for Respiratory Care, also known as the AARC. He has lectured at regional, state, national, and international conferences on topics pertaining to respiratory care. His research interests include simulation-based education and emergency and critical respiratory care. Brady is a fellow of the American Association for Respiratory Care and the American College of Chest Physicians. Brady, welcome, and I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
I am, Emily, and thank you so much, and good morning or afternoon to everyone who's here. Today's webinar will be, the title is, again, Ventilatory Strategies for the Patient with the Flu. We're very fortunate to have an extremely qualified speaker presenting on this topic. Today's speaker is a friend and a colleague of mine, John Davies. John is a registered respiratory therapist and the clinical research coordinator at Duke University Medical Center in Durham, North Carolina. John's research interests include advanced mechanical ventilation techniques and adult critical care. He has published a number of papers in the literature and has presented at various national and international conferences. I'd like to remind everybody or let everyone know that this educational activity is approved for 1 contact hour. There's a link. A link will be available at the conclusion of this webinar to obtain your CE credits. I'd also like to mention that support for this educational activity is provided by Philips Healthcare. John discloses that he is on the advisory board for ResMed and is a consultant with Teleflex. Now I'd like to turn everything over to John. John, are you ready?
I am. Thank you, Brady, for that kind introduction. As Brady mentioned, we're going to be talking about ventilatory strategies for the patient with the flu. The learning objectives for this talk are to examine the strategies, the early strategies such as non-invasive ventilation, high-flow nasal cannula, that are directed at preventing intubation and subsequent mechanical ventilation. We'll then discuss the use of conventional ventilation and look at ways to optimize oxygenation and ventilation while at the same time preventing ventilator-induced lung injury. And we'll wrap up with an examination of the strategies that are available for use when conventional ventilation fails. So the general outline is I'm going to look at the clinical path of initially 2 patients who developed the flu. We're going to look at the presentation and initial strategies that are available to us. Then we'll move on. Once the patient gets intubated, we're going to look at the evidence-based strategies for conventional ventilatory management, and then we'll end up with an outline of the rescue strategies that are available once conventional management of the ventilator fails. So I'm going to start by talking about an initial presentation of a gentleman that comes in with COPD because they present kind of multiple issues in terms of respiratory failure. So this is a 65-year-old man with COPD presenting to the emergency department with fever, dyspnea, diminished breath sounds, and accessory muscle use. He was brought in receiving nasal cannula at 4 liters per minute. He does test positive for the flu. A blood gas is drawn, and the results are shown here: PO2 of 51, PCO2 of 82, pH 719, and a bicarb of 33. And this is his chest x-ray over on the right. So you look at this, you have the information that was presented to you. What do you think the next course of action should be? And I put this up. This is hot off the press. The official practice guidelines from the European Respiratory Society and the American Thoracic Society, looking at indications for non-invasive ventilation, and certainly the highest evidence points towards its use in a patient with COPD or with an exacerbation. So I think, you know, the literature has shown this over the years. We finally have some official guidelines that this is the very highest degree of evidence. So I think there's no argument here as to what should be used. It should be non-invasive ventilation. The patient has hypoxemic and hypercarbic respiratory failure, both of which non-invasive may be able to reverse. So when we talk about putting this patient on non-invasive ventilation, there are some considerations we need to take into account. The first thing is clinician expertise. Putting a patient on non-invasive ventilation is not the easiest thing a respiratory therapist has to do. It takes some technique to ease it on the patient. You don't want to slap the mask on the patient at the full setting, because it'll take their breath away, make them uncomfortable, and they probably won't tolerate the mask. So you want to ease it on the patient. You want to know what kind of settings are you going to use. And I'd make the argument that because of hypoxemic and hypercarbic respiratory failure, that we need to use 2 pressure levels, or in other words, BiPAP, maybe 12/5 in this case, but I wouldn't start at 12/5. I would start at a low level, get him used to the feel of the mask, and then work your way up to the settings you think he should have. And then, of course, there's the FIO₂ as well. And then you think about, you know, what types of equipment are available. So there's many different types of masks, different shapes. I put here probably the 3 most common ones: an oral nasal mask, a couple types of full face masks. I did not include the nasal mask because in all reality, that most patients don't tolerate it as well, and they tend to, you know, breathe through their mouth, and it just doesn't seem to work as well. These are the ones that the patients generally like to use: the oral nasal mask at the top, and then the next 2, which are full face masks. And most patients like the full face mask because it's less claustrophobic. You don't have all this apparatus kind of right in front of your eyes. You can see out and see what's going on. So the mask is very important, because it's got to be comfortable for the patient, or they're not going to tolerate it. The type of ventilator that you're going to use. Most of the time in the emergency room, there's portable pressure ventilators are available. They generally, and this is the V60 here, they generally do a very good job at leak compensation and are the preferred ventilator in most cases. There are critical care ventilators that have non-invasive ventilation, but there's some question as to whether their leak compensation is quite as good. So one of the things with the V60, you see, it looks like it's going to be a single limb type of ventilation. The critical care ventilators give you the ability for double limb ventilation. So those circuits, when you're putting a patient on and you know, dealing with the ventilator, operate a little bit differently. So the other thing we have to think about is the circuit, as I mentioned, single limb versus double limb. With the V60, there is a filtered circuit, which is desirable with a flu patient, because it helps protect the caregivers and the clinician, as well as the other patients that are down there in the ER. So it's a filter or a filtered circuit that is designed to facilitate filtration of the patient's exhaled gases. And it goes without saying they're for use with patients with a known or suspected contagious disease. There still will be some leakage around the mask, potentially, that could get out into the environment, but then that's why it's important to get the best fitting mask and the most comfortable mask for the patient. So this filtered circuit adds an additional layer of protection for the clinicians. For this particular circuit, there is a setting on the ventilator called the DEP setting for the exhalation port. And keep in mind that this will be ineffective if it's used with a mask that's got one of those built-in leaks, because the majority of the exhaled gases will go out the leak and not through the filter. And then the usual things you have to look for with a filter and a circuit: watch for water buildup, do the humidification, condensation. The other thing is you may have to, depending on where you're going to put the nebulizer, I'll talk about this in a second, you don't want the filter to interfere with any type of aerosolized medication being delivered to the patient. And speaking of aerosolized medications, you're looking at a very simple diagram. With the ventilator, humidifier would be here and fixed leak here. So what you don't want to do is put the nebulizer down here near the humidifier, because most of the flow will go towards the patient and then out the fixed leak. So you want to rig it up so that you've got the nebulizer between the fixed leak and the mask. Now for the masks that have the built-in leak, that's kind of a more of an issue as well. But there are products out there like the Nevo that can actually be adapted to the mask and can deliver medication post leak, which is desirable in that particular instance, because the leak is here, nebulizers here, so the majority of the medication should go towards the patient. So things to keep in mind, because especially with the COPD patient, they are in all likelihood going to receive aerosolized medications as well. So that's kind of starting with a patient that's got a mixed bag of hypoxemic and hypercarbic respiratory failure. Let's look at another case presentation. This is a 36-year-old man who presents with fever, shortness of breath, productive cough, fatigue, and muscle aches for 3 days. On exam, he has a temperature of 38.6, BP 140 on 85, heart rate 115, respiratory rate 28, and he's satting 81% on room air. He does appear uncomfortable, but is alert and oriented and able to speak, but only in short sentences. He's moving air well bilaterally and has crackles in his lower lung fields. He, like the previous gentleman, tests positive for the flu. He's placed on 6 liters of oxygen by nasal cannula, and his SAT increases to 89%. However, he still desaturates to the low 80s with any type of coughing or any type of movement. A chest x-ray and ABG are performed. And there's his chest x-ray on the right. And the blood gas is to the left, pH 747, PCO2 31, PO2 37. That gives him a PF ratio of about 176. So the decision's made to escalate care. So what should you do next with this particular patient? And Fratt and his colleagues made the argument that perhaps high-flow nasal cannula should be the first line of treatment in patients with purely hypoxemic respiratory failure. And this is a study showing the incidence over here on the right of intubation, high-flow nasal cannula or high-flow oxygen versus standard oxygen and non-invasive ventilation. You see that the incidence of intubation was less with high-flow nasal cannula. And over on the left is the probability of survival. Certainly was significantly higher for high-flow nasal cannula versus standard oxygen and non-invasive ventilation. So this was kind of the first study that brought to light that perhaps high-flow nasal cannula does have a place in purely hypoxemic respiratory failure, which this gentleman has. But I think more work needs to be done with it. This is a meta-analysis done last year, and the top panel looks at, this is incidence of intubation, and the top one looks at high-flow nasal cannula versus just conventional oxygen therapy, and you can see from the graph that there's a clear clear benefit in terms of intubation rate with high-flow nasal cannula. However, when they went to compare it to a non-invasive ventilation, there was no such distinction. In other words, there didn't appear to be any benefit of high-flow nasal cannula over non-invasive ventilation. So I think it's where we are right now. The point is that we have a little bit of evidence, but for the flu patient especially, you try what you think is going to work initially, and then you may have another tool that you can use with them, either non-invasive ventilation to high-flow nasal cannula or high-flow nasal cannula to non-invasive ventilation. And the underlying thing you have to consider is which one, if one's working, just stay with it. If it's not working and you have time, you may be able to try the other one. So I'm going to put these patients back together. So they're now one patient. This one patient continues to deteriorate and is transferred to the MICU where he's intubated and placed on mechanical ventilation. So thinking about mechanical ventilation, what conventional management strategies need to be employed with this patient? So just reviewing lung protective strategies, we want to avoid the extension of lung injury. So we want to minimize oxygen toxicity. We want to limit the tidal stretch to prevent what's called volume trauma. We want to minimize the plateau pressure to prevent volume/barrel trauma. We want to be able to recruit, so prudent use of PEEP is needed, and we want to also prevent atelectasis, or what's called atellect trauma, which goes hand in hand with recruiting alveoli by using PEEP. So I'll briefly discuss each of these. So this is a pressure volume curve showing airway pressure on the bottom, volume up the y-axis, and this is inspiration here. You can see gas going into the patient, and you can see a point here, they call it the lower inflection point, where it's hypothesized that most of the alveoli become open, and then as you apply pressure, you get the most bang for your buck in this area here, right in the middle, and then you reach an area where what's called the upper inflection point, where you may start over-distending. So just to kind of review, this is where volume trauma occurs up here, and this is where atellect trauma occurs. So if we allow those alveoli to collapse right down, it's going to be harder to open them on the ensuing breath. So we want to sit right in here. So the problem that we have with these patients, because they develop ARDS, is that you have an alveol, you have an area of the lung that looks like this, consolidated, full of pro-inflammatory mediators, difficult to ventilate. And then you have relatively normal areas of ventilation. So the key is we try to ventilate some of these areas, but we have to be careful we don't over-distend these areas. So that's the ongoing battle with a patient with ARDS. So this is a CT scan of a patient that's got ARDS, and area A here represents this graphic here, is where the majority of the consolidation is. There's probably no gas exchange going on here. There's this area B here, which is the intermediate area. There's some collapse, there's some healthy units, and then there's area C where the units are all relatively healthy. And you can see that when trying to ventilate this lung, the only areas that you really have to work with are right up here and a little bit here. So we have to be careful what kind of volumes and pressures we use. To the right is an actual CT scan of one of our ARDS survivors, and this is months later. And you'll note that area A, the area that was consolidated and there was no ventilation taking place, is healthy. Part B, you can see that there are the white that you're seeing over here are fibrotic changes from injury to the lung. And you can see that there are some fibrotic changes in area B. If you look at C, the area that was healthy before is now the area that's injured. And that's because in this particular patient, we probably had to use larger than pressures than we wanted, maybe more support than we wanted to save him. So there's area C there. So how do we do it? Well, the first thing is, and we all know about the study, I'll just briefly review it, limit the tidal volume 4 to 8 mils per kilogram ideal body weight, limit the plateau pressure to less than 30, and prudent use of PEEP for recruitment without causing over-distension. So the tidal volume issue, this is from the study back in 2000, using 6 mils per kilogram versus 12. The mortality rates were much higher in the 12 mils per kilogram group. The trial was stopped a little bit early because of the mortality benefit. The tidal volume and the plateau pressure were significantly lower in the lower tidal volume group, as you would expect. Which group do you think had better PO2s? And this came as a surprise to us. 12. They had better PO2s, and I remember starting this study thinking everybody was crazy because we had better saturations with the patients with higher tidal volume, but they also died more often, as we can see right here. So just to caution people, a better PO2 and better PF ratio does not necessarily translate into better outcomes. So, and here's the 6 mils per versus 12 mils per kilogram comparison using PF ratio and study day. The dark circles are the high tidal volume group. The white squares or triangles, or I guess the squares, are diamonds, I guess. But they're the 6 mil per kilogram group. And you can see that the PF ratio was higher in the 12 mil per kilogram group up until about day 5. And the lines cross. And then the low tidal volume group had the higher PO2. So in this area is where the injury was occurring in the lungs, and eventually it manifested itself after about day 5. The plateau pressure, we've constantly, get told we need to keep the plateau pressure at 30 or less. The reasoning for that comes from the fact that the normal lung is maximally distended at transpulmonary pressure, and I'll talk a little bit more about this, between 30 to 35 centimeters of water. A plateau pressure certainly above the inflection point of the pressure volume curve does cause over-distension, but we'll talk a little bit more about what we really, so the plateau pressure is made up of 2 things. It's made up of the esophageal pressure, or well, esophageal, but basically the pleural pressure. The pressure required to push the chest wall out of the way, and then the pressure, the transpulmonary pressure, what the lungs actually see. So if we take a plateau pressure of 30, and we only need 5, this is a normal patient, we only need 5 to push out the chest wall, then the resultant pressure is going to manifest itself in the lungs. So in this case, 25. So transpulmonary pressure of 25, which is pretty high, but still deemed safe. So this is an actual scan of a patient of ours, and you can see that the patient is morbidly obese, but the lungs are relatively normal in terms of size. But all this adipose tissue surrounding the lungs is going to require some extra pressure to push out of the way so we can actually ventilate this patient. So this is kind of what you saw over here. So this patient had a ventilating pressure of, or a plateau pressure of 39. This is a normal patient. So if it was 39, normal pressure required to push the chest wall out of the way is 5. Transpulmonary pressure is 34. So this pressure would be dangerous in a normal person. However, in this patient, the same 39 centimeters of water, 30 of it's required to push the chest wall out of the way. So that means the lungs are only actually seeing 9 centimeters of water. So that's where this plateau pressure of 30 may not apply to the morbidly obese, and we have to keep in mind the 2 pressures that actually make up the plateau pressure. And this is, and how we measure the plateau pressure is with the esophageal balloon. Some of the ventilators can do this. In this case, you're seeing this is the pressure tracing. So this is a pressure hold up here. This is the esophageal pressure that's being measured, which is actually to overcome the chest. I'm sorry, the numbers are a little bit off, but you can see here the pressure required to push the chest wall out of the way. That means that the resultant pressure is only 9 in the lungs if we look over here at the ventilator. So you see only 9 is what the transpulmonary pressure is. Where it's also important is during exhalation. So if you have a PEEP of 20 here, but the esophageal pressure is 24, that means we don't have enough in the lungs to hold it open on exhalation. And what results is a negative transpulmonary pressure. What happens when you have a negative transpulmonary pressure? The lungs collapse. So the other thing by applying PEEP to these patients is you want to keep the lungs recruited during exhalation, and so that the plateau pressure and the PEEP may mean two different things with the morbidly obese patient. But it's important to, even if you don't have esophageal manometry, to keep that in mind, that you may need to use higher pressures, and it may in fact be safe for them. So how do we set PEEP? Well, ideally, we could use a CT scan. Electrical impedance tomography is available in Europe. It's being tested here in the United States. It measures, it can give you actually pictures of the lung and of recruitment. Unfortunately, those two things, you're not going to take a patient down every time you make a PEEP change to, you know, do a CT scan on them. So those things are not going to be done at the bedside at this point in time anyway. So there's other things you can do. Those PV curves that we saw, best compliance has been suggested, but I would say that judging by the compliance that was, you know, that we saw, the increase in compliance that we saw in the high tidal volume group of the ARDS study, that maybe that's not the best thing to use. There's something called the stress index, which is gaining a lot of traction. I'll talk a little bit more about that because that can be done right at the bedside. More often than not, we use PEEP FIO₂ tables. So, you know, we look at the gas exchange. The goal, you know, it's adequate. We're not looking for maximal PO2. That actually was the practice about 30 years ago, unfortunately. And so the goal is just to have an adequate oxygenation. So this is a comparison of the ARDS study. We after the tidal volume study, the ARDS did a high versus low tidal or PEEP study. There were two other trials, one in Canada and one in Europe. And again, they looked at high PEEP versus low PEEP. You can see that this is the compliance of the respiratory system, which was higher with the high PEEP group. PF ratio was higher in the high PEEP group. But guess what? No mortality benefit to the aggressive versus conservative PEEP in any of these trials. And you can see that the plateau pressure was approaching dangerous levels by using the high PEEP group. However, there was a group that did a post hoc analysis a few years later that separated the patients out that had what would qualify today as moderate to severe ARDS versus those that had mild ARDS, or at the time ALI. And they found that the high PEEP group, actually the patients that had ARDS, there was a mortality benefit. That's the high PEEP group there, and this is the low PEEP group. However, the curves switch with patients that do not have moderate or severe ARDS. The high PEEP group actually has worse mortality than the low PEEP group in patients without severe or moderate ARDS. So that's led to, if you go on the ARDSnet website, you will see that they have two PEEP tables, each designed to be used for different patient populations. I'm not going to go through these, I don't have time. But basically, the higher PEEP group ramps up the PEEP a little bit sooner. They still go out to the same endpoints, but in the high PEEP group, or in the ARDS group, the high PEEP, low FIO₂, they ramp up the PEEP earlier. So those can be easily acquired on the website and used for clinical practice. Here's the stress index. So this is something that Marco Ranieri and Grasso described a few years ago. And what you do is you put your patient in volume assist control with a square wave of flow, and then you look at the resultant pressure tracing. And what you should have, if you have recruitment going on throughout the breath, is a linear curve right here. That's referred to as a stress index of 1. There is a formula for this. I didn't want to bore you with it. It's probably more important just to look at the shape of the curve. So this is a stress index of greater than 1. And what you're seeing is you've got a linear curve, and you reach a point where all of a sudden the pressure shoots up. So that's indicating to you that you probably have some over-distension at the end of the breath. And that's defined as a stress index of greater than 1. So the reverse is the stress index is less than 1. So you have a linear start to the breath, and then the waveform bows down a little bit, indicating that you've opened up some other areas for recruitment, and then in fact you may be able to add some more PEEP to get to this, to the stress index of 1. In this case, you may want to drop your PEEP, You have to examine what your options are at that point. But the thing I like about this is it's something that can be done at the bedside. We don't need any special tools for it. Keep in mind that the patient does need to be probably heavily sedated. If they interact with the breath, you won't get anything you can interpret in terms of the pressure waveform. But that's called the stress index, and we do use it from time to time at the bedside. There's the new kid on the block is something called driving pressure from Marcelo Amato's group. This is they analyzed data from 9 of their previous studies, which turned out to be approximately 35 or 3,600 ARDS patients. And they looked at the delta P as an independent variable for survival. And what they found, this is kind of a busy slide, so I'll go through this with you. What they found was over here is the airway pressure, and this is PEEP, and this is delta P. So the driving pressure is essentially the plateau pressure minus PEEP. We've sometimes used the descending pressure, but the driving pressure is plateau minus PEEP. So in this one, the first panel, they kept the PEEP the same and increased the driving pressure. And down at the bottom, we have the multivariate risk of death in the hospital. And you can see that the possibility of death increase. It kind of mirrors what happened with the driving pressure. The next panel shows the driving pressure kept the same, but the PEEP was ramped up. What happened to the chances of death? Nothing. It stayed essentially the same. In the third panel, they started with a higher driving pressure and worked their way down and increased the PEEP as well. So they decreased the driving pressure, increased the PEEP, and the risk of death went down with that. It was the same total pressure, just they got to it in 2 different ways, using PEEP and decreasing driving pressure. So this is something that I think we do need to keep in mind. We think back to that CT scan we saw of the patient that had a lot of consolidation, and the functional size of the lung was in fact much smaller. So this makes a lot of sense when you think of this from that perspective. And what they concluded as they looked at the risk of death and they looked at the actual driving pressure, and right around 15 or so, they determined that the risk of death started going up exponentially after this driving pressure of 15. So they concluded that we need to keep the driving pressure 15 or less. Now, there's been another study that came out looking at it was a retrospective look at driving pressure in patients without ARDS. Again, there's more study that needs to be done on this. This was a retrospective study. It was not a randomized controlled trial, so we need to keep that in mind. So despite your best efforts, the patient continues to deteriorate. Here's his blood gases, PO2 45, CO2 81, now his pH is 717. Vent settings, he's on pressure assist control, inspiratory pressure of 22, PEEP of 14, 100%. And you'll note that his combined pressure puts him in a danger level of 36. So at this point, we need to consider what else is available to us. So there's the chest x-ray. What do we do next? So here's the rescue strategies that are available. Neuromuscular blockade, prone ventilation, APRV, HFOV, inhaled pulmonary vasodilators, and extracorporeal membrane oxygenation. I'm not going to go into any of these in a lot of detail, but I just want to highlight which ones maybe have a little bit of promise and others that, maybe they're just for the trying. We don't know. So this is a study by Papazian back in 2010, I believe, looking at neuromuscular blockers in early ARDS. 340 patients randomized to receive CISAT versus placebo for the first 48 hours. Then they looked at the 90-day mortality. And the graph over on the right shows you what happened. Right around day 18, the curve started separating. We don't know yet we don't know for sure what the Reason for this is some think that it's better patient ventilator synchrony. Some think that when they're paralyzed, the release of pro-inflammatory mediators is minimized. We're not really sure yet, but what we did see is that there seems to be a benefit of using CSAT in the first 48 hours. So neuromuscular blockade, it may promote patient ventilator synchrony. Looks like it improves oxygenation. It's, for all intents and purposes, readily available, and it may reduce ventilator-induced lung injury. The cons, it can lead to prolonged weakness and myopathy, especially if steroids are being given. It can worsen ventilation by taking away any patient effort, and may in fact lead to higher pressure requirements. And sedation is always an issue with neuromuscular blockade, so it can lead to over or under sedation in these patients. So continuing on, prone ventilation is something that's gained a lot of popularity in the last 8 years or so. And generally, when you turn somebody prone, you change the way gas gets distributed in the lung fields. It redistributes the opacities. You have changes in pleural pressure, and we've seen it. Certainly we see increases in oxygenation. And here's a patient in the supine position. The dark area is aerated lung. Non-aerated lung is represented by the light blue there, and you can see that the areas of aerated lung in the supine position. If you flip them over, you can see that the area for to take part in gas exchange is much larger. So the theory is you're able to recruit more lung, leading to better oxygenation. The question is there any more mortality benefit to all the work you're doing in flipping these patients? Well, so Guerin in 2013 looked at this. They looked at proning for 16 hours versus just being supine, and they found a huge reduction in mortality, almost in half by raw numbers, but 17.4 absolute reduction in mortality in the prone group. Now, this is interesting. I'm going to make this point because I think it's important when we talk about rescue strategies. This group has done, they've, at least before this study, 3 or 4 other studies with proning that showed no mortality benefit. Now, granted, it was done for different durations, but I just want to point out that the other thing that may be at play here is this group is they're probably the experts at proning. And so that any of these rescue modes, I think the level of expertise varies widely, and if you're not sure what you're doing with it, you may not be in fact helping the patient. But in any event, in this case, on about their 4th or whatever it was, 5th try, they found a signal, and again it was 16 hours that they proned the patient, which was longer than the previous studies. So the advantages: improves oxygenation in most of the patients very rapidly, usually has a lasting effect too, even when we flip them back onto their back. There's more lung recruitment, seems to be more uniform ventilation. The cons: anybody that's prone to patient knows about all of these. Pressure sores, ET tube obstruction, all the secretions migrate to the tube. Loss of airway and lines, that's, the airway especially is a emergent situation, as you can imagine. Increased need for sedation. They're not all that comfortable lying on their stomach for that length of time. So a little bit of evidence to support neuromuscular blockade and prone ventilation. Airway pressure release ventilation is available on every ventilator, albeit it's called something different on every one as well, but basically is long periods of CPAP with releases or deflations superimposed. And the idea is that you have long areas of CPAP, so this is where your gas mixing comes in, and then your CO2 removal occurs during the brief releases. And spontaneous breaths now occur during inspiration as opposed to like regular SIMV where they would take place on exhalation. And I will caution you that this mode is used, you'll notice it's in rescue. The reason it's in rescue is because the main reason for this is for oxygenation because of this long I time. Throwing spontaneous breathing on there is an advantage, perhaps hemodynamically, but it's not the main reason that we use airway pressure release ventilation. A lot of the manufacturer will say to you, well, they can breathe spontaneously. What they're talking about is we used to do inverse ratio ventilation very similar to this, just on a regular ventilator. Now we could only go to 4:1, and the patients were extremely uncomfortable and could not breathe spontaneously. So that's what they're talking about. So whether the spontaneous breathing has a huge benefit remains to be seen. So the clinical issues with APRV, as I mentioned, spontaneous breathing may have some benefits hemodynamically, but spontaneous breathing also, because of the negative pressure, you're subtracting a minus pressure, can add to the transpulmonary pressure. So if you're at your T or P high is at a high level, and you've got a patient breathing, with a fairly hefty drive, you may actually be putting that transpulmonary pressure in the danger area. Is it more comfortable? The evidence out there shows that it's conflicting. One recent study showed that it actually required, the Maxwell study in 2009 showed that it required more sedation. So the jury's out on that one. As I mentioned, it's certainly more comfortable than inverse ratio ventilation back in the 90s, but we don't do that anymore. Is it an easy mode to set up? Well, the terminology is different on a lot of the different ventilators. There's no standard way of setting it up. What a lot of people are basing their information on is animal studies and lab studies that are being done, and they rely on T-low to create auto PEEP. And so, identifying what the T-low should be set up to give you the adequate amount of auto PEEP is a huge challenge. The other question that's been raised is that because auto PEEP tends to go in areas that are already over-distended as opposed to applied PEEP, is it better to use auto PEEP or applied PEEP? And we don't know the answer to that, but if you look at the physics of it, you'll find that auto PEEP or applied PEEP distributes better than auto PEEP. And there's always trade-offs. If you're trying to make a vent change for oxygenation issues, you're going to affect ventilation and vice versa. There are no outcome studies. I will reference a recent study that just came out, I think in December. 138 patients, they used APRV versus low tidal volume strategy, and found that there was an increase in ventilator-free days in the APRV group. So I'm going to, again, we look at these studies, and a lot of people tend to look at the abstracts, but if you go back and look at this study, a couple things stand out to me. First, it was a single center study. The second was, if you look at the sedation, so they had a standard sedation protocol for both the low tidal volume group and APRV group. However, what they did was, after they got the baseline sedation, the APRV group, they titrated down the sedation so that the patients, to the point where the patients started breathing spontaneously. So in essence, what happened was the low tidal volume group got much more sedation than the APRV group. So it stands to reason that that may be a reason that there was that they had more more days on the ventilator than the APRV group. We don't know if what we need to know is if the sedation level was kept the same in both groups, what would have happened. So again, I look at this study and I think I'm not sure. I think there's still a lot of work that needs to be done in this area. HFOV used to be fairly popular. It's fallen out of favor, but the idea behind it is you ventilate with very small pressure swings, almost like using super PEEP, and so you keep a mean airway pressure in the lungs, and you don't have these big tidal swings that you have in conventional ventilation here. So you have this oscillation around a mean here. So it had appeal because it was, it looked very lung protective, and people were using it. And then a couple other studies came out. The first one's the Oscar trial, and it was done in Europe, 398 patients, HFOV versus local physician practice. They were encouraged to use a protocol but did not have to. So again, a flawed control group. They found no difference in mortality, conventional versus HFOV. And this is why I wanted to allude to that point earlier with proning. 3 centers had any type of meaningful experience with HFOV. 6 had limited, meaning what is that? They use it once every 6 months. We don't know. Then 20 centers had no previous experience with HFOV. And I can tell you, for those of you that out there that have used HFOV, that's a red flag right there, especially for us, because it took us a long time to get proficient. However, it is what it is. Neil Ferguson and the group out of Toronto piloted this study, 548 patients, 39 centers, 5 different countries. They used HFOV versus low tidal volume high PEEP strategy, and found that HFOV was actually worse, 47% mortality versus 35%. And you can see over here. A few issues with this study as well. They used a protocol that started with higher mean airway pressures, and combined that with the fact that two-thirds of the patients were on pressors. We know that patients that have blood pressure problems usually don't do well with HFOV, so I think that that was a problem off the beginning. Many centers, again, had little or no experience with the oscillator. And another fact that was pointed out, so these 75 patients were not enrolled because the investigators either felt that HFOV would be a benefit. Some of these did occur up in Canada where they are already on the oscillator and they didn't want to take a chance of them going to conventional ventilation. So, you know, it was peer reviewed, but there still are some issues, you know, with the control group and how these studies were carried out. So pros, I think that, again, like proning, HFOV improves oxygenation. It allows for higher mean airway pressures and reduces the tidal swing. A lot of cons to this too. Requires a specialized ventilator, can impair venous return, high levels of sedation, often paralytics, impaired mucus clearance, and I did put down does not allow for transport of the patient. However, there are some anecdotal stories of people rigging a system up where they could transport a patient. I wouldn't recommend it, but apparently it has been done. Inhaled nitric oxide, well, there's a couple studies showing, and these are meta-analyses of numerous studies, and they show the same things: transient improvement in oxygenation, no mortality benefit, and they cannot be recommended for ARDS. The one area where I've heard people use this nitric oxide is that transient improvement in oxygenation if you're getting ready for ECMO or another strategy. That may be indicated, but certainly not as a tool for ARDS. It's got lots of issues as well. It's costly, requires special equipment, could produce methemoglobinemia, rebound pulmonary hypertension, reactive nitrogen species, which really hasn't been studied that much. They may have pro-inflammatory or carcinogenic effects. And again, there's no outcome studies to support its use in ARDS. I'd like to end with ECMO. And what ECMO does, most of you guys probably know this by now, dissociates mechanical ventilation and gas exchange. You know, blood is removed from the patient and pumped to an artificial lung and then returned, and it gets oxygenated, CO2 gets blown off, and the patient's you know, effectively acting as their lungs. So you have the potential to reduce villi because, and we don't know the optimal strategy for the ventilator when a patient's on ECMO. There's been many suggestions we should go lower on the tidal volume, but we don't know yet. That's associated with high cost, anticoagulation is required, and it's very resource intensive. So, you know, what does the evidence say about this? And these people, the CSAR style study, extracorporeal lung support is what ECLS stands for. 180 patients with potentially reversible ARDS in the UK. And this was kind of an odd study because what they did was they randomized to usual care at that institution, or they wouldn't necessarily get ECMO. They would get sent to a center that does ECMO. So some of these patients didn't even get ECMO. They died. They were deemed too healthy. You know, for instance, 90 of them got randomized to ECMO. Only 71 of them got it. So 19 were deemed, you know, we can handle these patients on conventional ventilation. And there was lack of standardization in the control group. However, there was a survival benefit in patients that went to the centers that can do ECMO. There are some other smaller studies that may be producing a signal that might have, you know, mortality benefit. We don't know yet. But there's so many questions surrounding ECMO. When should it be initiated? How do you go about doing it? If you don't have ECMO, how do you get them to an institution? Which patients are the best candidates? You know, how do you manage the ventilator? What's the best strategy for weaning? I mean, do you take the endotracheal tube out completely before you stop ECMO? There's transfusion issues, anticoagulation strategies are involved, medication dosing changes, and nobody knows the long-term effects of ECMO. One of the things that we've learned very early on is when you go to ECMO, you better have an exit strategy up front, because if you get a patient that doesn't respond as well as you like, then it becomes a very ethically difficult situation pulling that type of life support off. To summarize and conclude, we think back to those patients that came into the ER at the beginning. You can see that there was a definite indication for non-invasive ventilation in the patient with COPD, and certainly any type of hypercarbic respiratory failure that might go along with hypoxemic respiratory failure. High-flow nasal cannula is another tool that can be considered early, but keep in mind that as it stands now, the evidence points to them high-flow nasal cannula being used in patients with purely hypoxemic respiratory failure. And again, you know, if you have time, you may be able to try, if you're on high-flow nasal cannula, you may be able to try non-invasive and vice versa. It all depends on time and, you know, how they're responding to what they're on right now. I think it's important to optimize conventional ventilation. We saw this patient get intubated, and then now we have a different set of parameters we need to consider in order to optimize what we're doing for the patient. And that is limiting the tidal volume to 4 to 8 mils per kilogram ideal body weight, keeping the plateau pressure less than 30 centimeters of water, prudent use of PEEP. We want to recruit. Use the PEEP to recruit alveoli, keep the recruitment during exhalation, but we also want to prevent over-distension. So it's a balance of that, the using of that PEEP. And there is a new kit on the block, something called driving pressure, which looks at the plateau pressure minus the PEEP, and that kind of directly addresses the so-called functional lung that's available for ventilation. More work needs to be done with that, but it is out there now, and it's another consideration that we tend to use along with the first three that I mentioned. I think that as we move into areas where we call them rescue modes or conventional ventilation is failing, you got to do something else. Certainly there's evidence of using neuromuscular blockade, which actually would probably be employed while you're still on conventional ventilation, and prone positioning, which has shown a significant decrease in mortality about 3 or 4 years ago in patients that have any type of ARDS, but in particular, you know, flu-related ARDS. And then there are several other modalities or adjuncts that are available. There's no clear benefit of one over the other. And in your institution, you may have one and not the other. So it depends on what you have, what you're comfortable with. And, you know, just as in terms of how you're going to treat this patient once conventional ventilation fails. And with that, I'd like to thank you for your time and look forward to any questions you may have.
Thanks, John. That was really outstanding. Just real quick, I would like to remind everybody that this education activity is approved for 1 contact hour. And to obtain your CE credits, please go to the website there, saxtesting.com/BO. And again, I'd like to mention again that the support for this educational activity was provided by Philips Healthcare. So John, we have good questions, and I'd like to start out with non-invasive ventilation. And you started out the talk about non-invasive ventilation, and really the question came from Julie, and the question was, how long do you typically leave a patient on NIV? Thinking about that COPD patient with flu, how long would you leave that patient on NIV before you made the decision to intubate?
Yeah, that's an excellent question. Normally speaking, we would probably give them at least an hour, but you should see some improvement almost immediately. And so in a COPD patient, if they kind of level off and, you know, you've stopped them from getting worse, but they're really not getting any better, I'd give them probably about 2 hours. With the flu patient, I would say much earlier, because they tend to progress and get worse seems to me much quicker. So I would give them maybe 30 minutes if you have that kind of time. At the same time, you know, looking at your other options. You know, again, we have some COPD patients, so, you know, they become a handful because they've got two issues, but I wouldn't give them 2 hours if they're not starting to turn around.
Yeah, I would agree. I think the literature is supportive of the same. I think that 1 or 2 hours, then we have to start making decisions to intubate. Another question that we had was from Destiny, and the question was, John, about proning. And the question was, are there any negative cardiovascular side effects of proning that we're aware of? And if so, how do we manage that?
That's a great question. I'm not sure. I'd have to go back and look at the literature. I mean, our own experience seems to be patient specific. I would be nervous with somebody that's got significant heart failure, you know, with all those fluid shifts when you flip them over. I don't know though that there is a strict answer to that question, but you know, these patients, if it's just if it's just the lungs, it's probably not a problem. If they have some heart disease or some other hemodynamic issues that go along with their ARDS, then we'd have to consider that change in position. And I think that the shift in fluid, you know, you may be shifting some of that fluid extravascularly. We don't know, but that's an excellent question. I think that's another thing when you talk about these strategies. It's not just the lungs you have to take into account. It's the other systems that may be affected by it.
Yeah, that's true. There are definitely several contraindications. And you think about like spinal instability, and you know, and almost with almost everything we do, or a lot of things we do, is the contraindication would be hemodynamic instability. But I think that if you're stable, from what I know, based on the literature, if you're stable, even on vasopressors, if you're keeping your MAP, you know, above 65, then the patient may still be prone.
Yeah, I agree with that.
And so this question came from Carl. The question was, how do you keep driving pressure the same during mechanical ventilation while you're increasing the PEEP?
Well, remember, the driving pressure is the plateau pressure minus the PEEP. So increasing the PEEP does not affect the driving pressure. It just pushes the total pressure up. So if I don't have the Amato slide up, but if you look at it, that's there was that one slide where the third panel over where they actually increased the PEEP, they dropped the driving pressure. But if you kept that the same, the result would be that the total pressure would go up, but your driving pressure would stay the same. So it may put you in a danger area in terms of total pressure, but you may be okay still in terms of driving pressure. And I will say that when I showed the Amato slide, it's very clean, and you know, it's easy to kind of comprehend what he was trying to do. Clinically, it's not so easy. You've got a lot of other factors to take into account, but that's a good question, because you know, just keeping the driving pressure the same and increasing the PEEP may put you in a danger area in terms of the plateau pressure itself. We don't know that that's just keeping the driving pressure the same is going to, you know, obviate those issues.
Thanks, Sean. That was a great answer. I know that's kind of I think that you said it pretty well during the talk, that it's a relatively new concept, driving pressure is. Moving on to another question here that we have. This one came in from Paul. Paul's specific question was, does inhaled Floland perhaps have a role in these patients, and does its use change outcomes? And I'll expand on that. Does, you know, what about inhaled pulmonary vasodilators, just in general, even past Floland?
Yeah, that's a good question, and I didn't include it because of the time limitations, but since it's in the questions, we can address it. A lot of centers are looking at inhaled Floland or epoprostenol for as a alternative to nitric oxide, more from, you know, cost perspective, but there are some studies out there that look at mortality. I'm not aware of any mortality benefit at this time. They kind of do the same thing that nitric did. You get these transient increases in oxygenation, but I don't think that there's been any mortality benefit that's been discovered so far. You know, Brady, you may know. I'm not sure if there is one out there.
No, I'm not really sure either. I probably know I think I must be reading the same things you are in terms of mortality. I know that the institution that I work at now, we, you know, sometimes we do utilize, I mean, I can't tell you that we don't, even though that the literature is not strongly supportive, but somebody who's in refractory hypoxemia, at least while we're trying to come up with some other plan, we actually, we may either do inhaled epoprostenol or nitric oxide just to bridge us over for a certain period of time in certain situations.
And I will admit, some of our attendings will do the same.
Sure. John, can you comment at all? I had one comment here from Jose, a quite long comment actually. It sounds to me like this Jose at his institution, they use the VDR, the volumetric diffusive respirator. Can you comment at all about the VDR in some ARDS patients?
Yeah, so the VDR uses something called volumetric diffusive respiration, using something called the phasotron. And what it does, it basically does, if I'm describing this properly, it's describing pressure control ventilation with oscillations imposed on it. There, to my knowledge, are no mortality benefits that have been produced. I know there are centers that swear by it, and it kind of makes the same. If you think about the oscillator and the VDR, they kind of come from the same family, and I know that we still use the oscillator, and our therapists are very good with it, so we may have better outcomes, and the same may be said with those institutions that use the VDR. I don't have much experience with it, and the literature to support it in ARDS is scarce, but I'm not aware of any mortality benefit at this time.
Yeah, I agree. I've definitely met some folks through my travels that are proponents of the VDR. I don't personally have any experience, but you're right. I think we just need more data, right, to help drive some of these decisions.
Agreed.
I had a lot of questions here, John. You sparked quite the conversation here in the chat room, and I appreciate that from everybody.
So, John, there seems to be a couple questions here about high flow nasal cannula, and I think one question is, this was from Brad, and how does heated high flow nasal cannula compare to regular high flow nasal cannula in these patients? And Diane has a similar question where she asked about HFNC, high flow nasal cannula. Do you mean the OptiFlow or high flow nasal cannula? What I think that means is the high flow nasal cannula is also that terminology is also used in some of the other cannulas that have a little bit of a larger bore tubing, John, that goes from 6 to 15. So you were talking about the heated high flow that's much higher flows than 15 liters, correct?
Yeah, sorry, I should have, I didn't even think about that. Yeah, there are some systems out there that call themselves high flow nasal cannula that will take it up to, I believe it's 15, and they're not heated. No, I'm referring to the heated high flow that takes, gives you flows up to 60 or 75, where you can vary the FIO₂. That's what's been studied, or that when those studies that I put up, that's what they were using, and I think that's, now when you refer to high flow nasal cannula, that's what most people are talking about. But that's a good point. I didn't separate the two, because there is a product that calls itself high flow at 15 liters. So good point.
Yeah, thanks for the clarification. That's what I was thinking too. I just want to make sure that all of our listeners have that clarification.
Thanks for the question.
Yeah, that's really good. Here's a question that I know that you and I have both asked this question, and we've tried to answer it, and I've seen this question a lot, so this is good. This question's from Don. Don writes, when considering volume trauma or barotrauma, I'll say, is it okay in pressure control to have larger tidal volumes as long as the plateau pressure is below 30 to 35? For example, if you have a patient who's extremely air hungry.
Yeah. Oh, that does. Yeah, we've had this conversation.
We have several times, yes.
Yeah, it's the kind of ongoing battle of whether is it pressure or is it volume. My take on it is it's a little bit of both. I think we have to keep the tidal volumes as low as possible. Well, I mean the 4 to 8 target, but I think we also have to keep the pressure low, and maybe in particular a driving pressure, we don't know, but Yeah, in pressure ventilation, that's always a bit of a hot potato when you get these high tidal volumes. And I do know that, like, even somebody in pressure support, I get the question, my patient's in 5 of pressure support, but his tidal volume's 10 mils per kilogram. What do I do? And it's like, I don't know, extubate him, sedate him, put him on volume. I don't know. Each patient's a little bit different, but that's a great question, because just because you satisfy one area of ventilator-induced lung injury, pressure, what about the volume trauma if they've got tidal volumes of 10? And I would say that you still are going to damage the lungs because of the stretch and the strain that's on the lungs with the excessive tidal volume. But that is a battle, especially with ARDS patients, that you fight all the time. My pressure's okay, but my volume's not, or my volume's okay, but my pressure's not. Good question.
Yeah, it really is, and it's a question that is very, very, very often asked.
But it always happens.
It does. It's constant. Hey, John, I just want to switch real quick, since we got a couple more minutes, back to non-invasive ventilation, where we came from the beginning. Margaret was asking just simply about recommendations for settings, like in the setting of, I'm assuming, COPD and flu. And then there was another question here from Prethi that was the benefit, if there's any benefit at all from using a single-limbed circuit versus a dual-limb circuit in non-invasive ventilation.
Yeah, those are good questions. The settings, it depends on the patient. Certainly that patient that we saw, I would be thinking, I would start maybe 10 on 5 and see what happens, because the other thing is you're going to start low anyway to get the patient used to it. So you're going to start low and then escalate up as you see how the patient's responding. So, in the case of that patient, I would be inclined to start him around 10 on 5 with a higher FIO₂ at that time and see what happens. But yeah, that's a great question, because I know that she's probably had residents trying to tell her settings that are totally inappropriate at times, and we run into that too. Yeah, there's no real script for it, but I think that you have to recognize that you might need 2 pressure levels, to blow off CO2, and then, but the rule of thumb is you start low and you move up, and I would start around 10 on 5. I'm sorry, what was the second question? I lost my train of thought there.
No, sorry, I asked it 2 in a row. The question was about is there any advantage at all?
Oh yeah,
from single limb to dual limb circuits.
I think part of that has to do with the type of ventilator you're running. Some of them seem to perform better with the single limb circuit. It's more, I think, about the leak compensation and how it can manage leaks in the system. So the single limb circuit it's a little easier to set up. It's kind of comes with that V60, and the V60 does a good job of ventilating using a single lung. Single limb. Sorry, I can't speak to all the ventilators out there, but there are some ventilators that can't do single limb, and they do double limb, and they do a good job. So I think it depends on the type of ventilator you have as well. Brady, you got a lot of experience in this area. What's your thoughts on that?
Well, first of all, to go back to the settings, I 100% agree with you. In reality, I think, when you ask 100 respiratory therapists or folks that are using non-invasive ventilation, the first settings in COPD, a lot of them say 10 over 5, some say 12 over 5 or whatever, but in reality, it's you set a setting, 10 over 5, and then you have to make changes based on patient feedback. The patient, is worker breathing decreasing, is tidal volumes improving, is the general situation getting better. But I also want to make sure that it's really important, this kind of segues over to that limb, is 10 over 5 on one ventilator may not be 10 over 5 on the other.
Oh yeah,
and so some machines, 10 over 5, the 10 is a pressure limit, and 5 is an EPAP or a PEEP setting. And in some non-invasive ventilators, that 10 over 5 may suggest that you have a pressure support level of only 5. And that's typically what you would see on that. You showed a picture of the V60 earlier, and that may be how that is. So that's 10 over 5 with a pressure support level of 5. 10 over 5 on some ICU ventilators that may be using dual limb circuits would be quite literally 10 centimeters of water over 5
Yeah.
of PEEP, which would be a peak pressure of 15.
Yeah.
So I think most importantly, and again, this is a little bit of an opinion, but most importantly, I think it's just for us really to understand our devices and make sure that we're setting the settings up properly for the device that we have. And John, I think we are actually out of time and we need to wrap up. And those are actually some outstanding questions.
Yeah,
We had
enjoyed that.
so many that we couldn't get to, and I do apologize that we couldn't get to all of them. But again, John, I appreciate it as always. I enjoy working with you. And
Same here, man.
excellent presentation, especially nowadays we are dealing with flu in such a way. So busy with flu nowadays. And Emily, I will turn over to you.
I'd like to thank you very much for your time, both John, for this very informative presentation, and as well to you, Brady, for being our moderator today. It's been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.